minimally invasive procedure. So we'll be discussing about that. Now, before starting with the lumbar puncture, there are some prerequisites which you must know in order to understand the procedure. And I don't think so such kind of procedure you have studied till now. Okay. Till now you have studied directly about the gross structure, microscopic structure, then development or case-based studies, right? But about a procedure, how it is done, based on the anatomical knowledge, based on the surface anatomy, till now you have not studied. So this is for the first time. Okay. Now before going to the lumbar puncture, first, as I said, few things are there, few points which you have to know. Okay. I hope you have seen the vertebral column, everyone. Have you seen the vertebral column? You have seen the skeleton. So in that skeleton, I hope you have seen the vertebral column, right? Now here I have shown two images of vertebral column. Okay. Now you can see this is the lateral view of the vertebral column. This is the posterior view of the vertebral column. So the vertebral column is made up of what? The vertebral column is made up of vertebrae. Okay. How many vertebrae are there? You can see these are the vertebrae. Okay, these are the vertebrae. It is not made up of a single bone. It is made up of number of bones, and those are called as vertebra, singular. Together it is called as vertebrae. Now how many vertebrae are present? Total is 33. But if you see in case of adult, it is 26. Why it is 26? Because the sacrum and the coccyx. So total 5 sacral vertebrae are there. They will fuse together to form one sacrum. Okay, 4 coccygeal vertebrae, they will fuse together to form one coccyx. So number is reducing. That's why in case of an adult vertebra, how many bones you will be getting? 26. And in case of a small children, it will be 33, unless and until the sacrum and coccyx are fused. Okay. Next, I hope you have studied about the thoracic vertebra, right? You have studied about the lumbar vertebra also. Okay. So that's why we'll be discussing about the lumbar puncture. Though you are having some idea about the lumbar vertebra. Okay. And I hope you have studied the parts of the lumbar vertebra also. Okay. What are the parts in case of typical and what is there in case of atypical? Next, if you see the vertebral column, okay, I will request everyone to go and see the vertebral column. What is the whatever it is available in the department. Okay, you will see that some curvatures are there. If you see from the posterior aspect, you can't see any curvature. Okay, it will appear straight, but actually it is not straight. Some curves are there, and that can be well visualized from lateral view. Okay, so if you see the lateral view of the vertebral column, you can see some curvatures are there. Okay, I don't know whether you have studied or not. Okay, two types of curvatures are there: primary curvatures and secondary curvature. Primary curvature develops during intrauterine life when it is developing, and secondary curvatures develop after birth. Okay, so like this, two different types of curvatures are there. Next, inside the vertebral column, what is passing? Any idea? Spinal cord is passing. Okay, so if you have noticed the vertebral body, if you see the parts of the vertebra, you have seen vertebral bodies there. Okay, after that, if you go posterior to the body, okay, if you go posterior to the body, what is present? Body anteriorly रहता है. The most interior part is the body, right? How you hold the vertebra like this? By placing your hand on the spinous process. Okay, this is the way to hold the vertebra. So spinous process is the posterior most part. When you are holding a vertebra, how you will hold in a proper anatomical position? You will not pick the bone like this in the exam. Okay, you have to hold it like this. So the part where you are holding, that is the spinous process. Okay, and the spinous process is the most posterior part. Okay, now the most anterior part is the body of the vertebra. Okay, now if you come posterior to the body, you can see a foramen is there. It is called as vertebral foramen. Okay, now this vertebral foramen, each and every vertebra are having this vertebral foramen. Together they are forming the vertebral canal, and through that canal, what is passing? Spinal cord. Okay, that is also important, and that is related to the procedure. Okay. Now, though you have not studied which vertebra is this? Anyone? Which vertebra is this? Why you are saying that this is lumbar vertebra? Yes, very good, because you can see the medullary process, you can see the accessory processes, okay, and you can't see any costal facet in the body, which is present in case of thoracic vertebra. Okay. Now, I was talking about this particular foramen. So this is the vertebral foramen. So where the vertebral foramen is present, as you can see, just posterior to the body, a foramen is there, that is called the vertebral foramen. Okay. Now each and every lumbar vertebra is having that foramen. Okay. So if you put all the lumbar vertebra together, then what it will be form? It will be forming a canal. It is called as vertebral canal. Okay. Now through that canal, what is passing? Spinal cord is passing. Though you have not studied about the spinal cord till now, but you know that spinal cord is a part of central nervous system. Okay, it is the downward continuation of medulla. Now, these are the two schematic diagrams showing the external features of the spinal cord. Okay, external features of the spinal cord. Okay, first focus on this particular diagram. Two diagrams are there. This is the anterior view and this is the posterior view of the spinal cord. Okay. Now we will not discuss in detail about the spinal cord. Just a brief introduction. Okay. Now you know that spinal cord is a downward continuation of the central nervous system. So the medulla oblongata, after upper border of first cervical vertebra, it is continuing downwards, as you can see, spinal cord, and it is extending up to the lower border of the first lumbar vertebra. Okay, that is the extent of the spinal cord. I am talking in case of adult. In case of children, it goes up to L3. Okay. So all the scenarios, all the examples, whatever we will be discussing today, that is for an adult, not for children. Okay. So that is the extent of the spinal cord. Now, during the extent of the spinal cord, okay, the part where it is terminating, you can see this is the part where it is terminating and it is cone shaped. Okay. So at the lower border of the L1, the spinal cord is terminating. When it is terminating, it is cone shaped, and that is called as conus medullaris. It is called as conus medullaris, as simple as that. Okay. Next, can you see this particular structure? Can you see this particular structure? Okay. Now, from the spinal cord, okay, there is an area of spinal cord that is called a spinal segment, from which spinal nerves are coming out. Okay, spinal nerves are coming out, and that also, these are paired structure, means nerves are coming out from right side also, left side also, to a segment of the spinal cord which give rise to the paired spinal nerves. These are called as spinal segment. Okay, so from that segment the nerves are coming out. As you can see, the nerves are coming out. Okay, now each and every part of the spinal cord, for example, cervical segment, then thoracic segment, lumbar segment, they are giving rise to the spinal nerves. Okay. Now, if you see the spinal nerves of the lumbar, sacral and coccygeal part, okay, they take place more or less vertically. They are coming out more or less vertically. Okay. Now, that particular nerve fibers around the conus medullaris, they form a structure. Okay, they form a structure which appears as horse tail. I hope you have seen horse. Have you seen the tail of the horse? Okay, so that particular type of structure is formed over there, and that is called as cauda equina. Okay, that is called as cauda equina. Okay. Next, another important point which I have not mentioned, that is, if you see the length of the vertebral column and if you see the length of the spinal cord, which one is longer? Vertebral column. Okay, the length of the vertebral column is more as compared to the spinal cord, because the spinal cord is terminating over here, L1, lower border of L1. Beyond that, vertebral column is present, but spinal cord is not present. Okay. Next, another point, if you see a straight line which is coming downwards and attaching to the coccyx, okay, the thread-like structure, that is called as phylum terminali. Okay, that is called as phylum terminali. Now, the spinal cord which is situated inside the vertebral column, okay, it is covered by coverings. 3 layers of coverings are there. and those are called as meninges. Those are called as meninges. Means they are covering the brain as well as they are also extending downwards and covering the spinal cord. Three layers are there. What are those three layers? Dura matter, arachnoid matter and pia matter. Okay, three layers are there. Okay, which are covering the spinal cord. That is also important. Okay, because in between those covering, some important potential spaces are there. Okay, and today while discussing about the lumbar puncture, we have to know about a particular space, and that is called as subarachnoid space. Okay, subarachnoid space where CSF is present. Okay. Next, if you see, this is a cut section of the vertebral column along with the spinal cord. Okay. Now, in this particular diagram, what is this? This is the cut section of the spinal cord. Okay. Now, if you see the center of the spinal cord, can you see a circle can be seen? Now, this is called as central canal. This is called as central canal, which is present at the middle of the spinal cord. Okay. What is the function of the central canal? Through this central canal, the CSF is passing, the CSF flowing through the spinal cord. Okay, that's why central canal is very important. Next, if you see, this is the vertebral canal. Okay, this is the vertebral canal. This is the vertebral canal. Now, inside the vertebral canal, you can see all the layers. First, you can see the dura matter, then you can see the arachnoid matter, and you can see the pia matter. Okay, so inside the vertebral canal, okay, only spinal cord is not there. Along with the spinal cord, these coverings are also present. Okay, three layers of coverings are there from outside to inside. First is the dura matter, middle one is the arachnoid matter, and then pia matter. Details will be discussed in neuroanatomy chapter. Okay, now in between, so which is the most important part? Okay, why we are discussing this? There must be a reason. So the most important aspect of this particular part is this subarachnoid space. That means the space between the arachnoid matter and the pia matter. I hope you can see this space. Okay. Now, what is present in this space? As I said, CSF is present. Cerebrospinal fluid is present. Okay. I hope everyone, you have heard about the CSF. It is a clear, colorless, transparent fluid circulates through the ventricle. Okay. So inside the brain, ventricles are present. These are not the ventricles what you have studied in case of heart. Okay. Inside the brain also ventricles are there. Inside the ventricles, the production of CSF is taking place. Okay. Choroid plexuses are there which forms the CSF. Okay. Now after production, the CSF flows. Okay. For that a particular pathway is there through which CSF is flowing. Now it is a type of extracellular fluid. Okay, volume is approximately 150 ml. The range is 100 ml to 200 ml. Okay, and rate of formation 0.3 milliliter per minute. That is the rate of production. Okay, now the amount of CSF which is present, that should be maintained. If it increases, then what will happen? There will be increase in the intracranial pressure, which is harmful for the patient. Okay, and there are some cases where the intracranial pressure increases. Okay, among them one of the reason is the obstruction of the flow of CSF, obstruction in the flow of CSF. Okay, so I hope it is clear about this particular space. Now why I am mentioning this space? Because in the lumbar puncture means we are puncturing something and we are introducing the needle. Now once we introduce the needle, we have to advance the needle up to this particular area. Okay, so that the CSF which is present in that area, that can be withdrawn, that can be taken out. Okay, so the main aim of the lumbar puncture is to introduce the needle into a space. Which space? That is the subarachnoid space. What is present in the subarachnoid space? CSF is present. Okay, and then we have to take out the CSF. Why we have to take out the CSF? For two purposes. First is diagnostic purpose, second is therapeutic purpose. Okay, diagnostic purpose means the CSF which is collected, okay, it will be sent for pathological investigation, okay, to see whether any infection, inflammation is present or not. And then therapeutic means through that particular route we can inject different types of chemical agents, we can inject different type of drugs, okay, which is required. For example, antibiotics, analgesic, corticosteroids, all those things can be introduced. Okay, so two purposes are there. First is a diagnostic purpose, another one is therapeutic purpose. Okay. Now, inserting the needle into the subarachnoid space is not a matter of joke. Okay. Just imagine you are inserting the needle into the subarachnoid space. Okay, so it is not that simple. For that, there are some important points which you have to know, and that we'll be discussing today. Now, if you see the overview of the lumbar puncture, okay, so as I said, lumbar puncture is a minimally invasive procedure. Okay, minimally invasive means where small incision or some insertion of the instruments are done without taking a large incision. Okay, so this is the minimally invasive procedure which is done to withdraw the CSF for diagnostic as well as therapeutic purposes. Okay, now the puncture should be done. Now, in order to do the puncture, it should be done below the termination of the spinal cord. So, I have shown you the termination of the spinal cord. In case of adult, it is lower border of the first lumbar vertebra. That means, whenever the puncture is done, it should be done below the termination of the spinal cord. Why? Or else there may be chances of pricking the spinal cord, or spinal cord may get injured whenever the needle is inserted. Okay, that's why you have to choose a particular area or particular part where spinal cord is not there. Okay, but other spinal nerves will be present, spinal cord will not be there. Okay, now for that there is an important landmark that is called as interspinous line. Okay, that is called as intercristal line or Taffier's line. Anyone, have you heard about this? Have you studied the hip bone? Okay, in hip bone, have you seen the iliac crest? Okay, so what you have to do, you have to take both the iliac crest, highest point of the iliac crest. Okay, and then you have to join both the iliac crest by drawing an imaginary line. Okay, so that particular line is called as intercristal line or Taffier's line. Okay, and the midpoint will be the area through which the needle will be inserted. Okay, so that is the safe way, and in that particular point, okay, in that particular point, the interspinal space is L3 and L4, which is the most preferred site. Already we know that spinal cord is terminated at the lower border of L1. Beyond that, spinal cord is not there. That means if we are inserting the needle in between the third and fourth lumbar vertebra, that means it is safe. The spinal cord will not get injured. That's why that particular site is used in order to do the lumbar puncture. Okay, so as I said, a horizontal line joining the highest point of the iliac crest passes through the spine of the fourth lumbar vertebra. Okay, now therefore the interspinal spaces immediately above and below this landmark can be used safely, because in that particular area spinal cord is not there, so we can use that particular area safely without causing any damage to the spinal cord. Now in this particular area, if you see the subarachnoid space, okay, it is more spacious, it is more roomy, more amount of CSF is present, and in that the spinal nerves are floating. Okay, so as a result, what will happen? The chances of causing damage to the spinal cord is very least, very minimum. Okay. Now, whenever the needle is introduced during the procedure, what will be the position of the patient? The position of the patient either in sitting position or in lying down position. Now, when the patient is in lying down position, it should be in lateral decubitus, either right lateral or left lateral decubitus. Okay, and flexion of the spine is required. Okay, flexion of the spine like this. Okay, flexion of the spine is required. Now, why the flexion of the spine is required? In order to introduce the needle, it is introduced through the interspinous space. Interspinous space. So you know that spines are present in the vertebral column. Okay, so between the two spine, the area which is there, that is called interspinous space. Okay, now in order to introduce the needle, we have to enlarge that space. So how we can enlarge? Simply you have to ask the patient to flex. Okay, in sitting position or in left lateral decubitus position, any position. Okay, patient has to do the flexion of the vertebral column, so that the interspinal space will increase, okay, and through that the needle can be introduced easily. Now, when the needle is introduced, the needle passes inward somewhat cranially exactly in the midline. Okay, so that is the direction, cranially inward and cranially, that means in upward direction the needle is introduced. Okay. Now, whenever the needle is introduced, there are some soft tissue which you will be encountering. That means you have to pass through the layers, different layers where different ligaments, okay, skin will be there, subcutaneous tissue, all those things will be there. You have to overcome those, and then ultimately you will be reaching the subarachnoid space. Okay. Now here you can see a schematic diagram. In this schematic diagram, you can see how the needle is introduced. Okay. So here these are the spinous processes. Okay. So first, after drawing the intercostal line or the Taffier's line, okay, the midline of the Taffier's line will be the ideal point through which the needle can be introduced. Now, when we are choosing that particular area, as I said, what you have to ask the patient to do the flexion of the vertebral column. Once the flexion is done, the interspinal space is increased. So this is the interspinal space. This is the interspinal space. Okay. Now in this particular diagram, you can see where the spinal cord has terminated. See the termination of the spinal cord at the lower border of the L1. Okay. But we have selected the site between L3 and L4. So here spinal cord is not there. Spinal nerves may be there, but spinal cord will not be there. Okay, and this particular part, though spinal cord is not there, that's why the space is more. The subarachnoid space is wider in that particular area. Okay, more amount of CSF can be withdrawn from this particular area. Okay, that's why this area is used generally. Okay, through the, now what are these? These are nothing but the spines of the vertebra, and through that it is inserted. Okay, so this particular spinal lumbar puncture is also called as spinal tap. Okay, and it is a very commonly done procedure, particularly to involve the sampling of CSF, okay, from the spinal cord. Now there are some other areas also from which the CSF can be collected. Okay, for example, some cisterns are there. When we will discuss the nervous system chapter, at that time we will come to know about the cisterns. Okay, from cisterns also the CSF can be collected. Now this particular lumbar puncture was developed by Henrik Quinke in late 19th century. Okay, at that time it was gold standard. Okay, because at that time the diagnostic imaging modalities were not that developed. Okay, for example, nowadays if any patient is suffering from meningitis, okay, easily with the help of CT scan or MRI it can be diagnosed. But at that time those imaging modalities were not there. Okay, so for that the best way to diagnose any type of sort of pathology related to central nervous system was take out the CSF and do laboratory investigation. Okay. Now another important point, with the help of this lumbar puncture, okay, with the help of the lumbar puncture we can also measure the intracranial pressure. Okay, first we can withdraw some amount of CSF, okay, that will be sent to the laboratory for various investigation, and along with that we can also measure the intracranial pressure with the help of manometer. Now these are the you can say layers which you will be encountering when the needle is inserted. Okay. Now here you can see the direction of the needle. As I said, always it will be in cranial direction, cranially, okay, upwards and inwards. That is the direction. Now once the needle is inserted, different layers will be there through which the needle has to pass. Okay, so you can see all the layers. So first, what will be the which part will be encountered first? Skin. As simple as that. Okay, because patient suppose in sitting position, okay, flexing the trunk. Okay, so you have to put the needle, okay, from the back. So first you will be getting the skin. So after skin, subcutaneous tissue is there. Okay, once the subcutaneous tissue is breached, then you will be getting the supraspinous ligament and interspinous ligament. Though you have studied the vertebrae, I hope you know about the interspinous supraspinous ligament. Okay, so as you can see in the diagram, okay, first see this is the skin. ये देखो, this is the skin, then this is the subcutaneous tissue, then this is the supraspinous ligament. Okay, then this is the interspinous ligament. Okay, once the interspinous ligament is reached, then this is the epidural space. Okay, epidural space. Epidural space means the dura mater and the vertebral canal. In between that, the space which is there, that is called as epidural space. Okay, now in another one important point related to the epidural space is epidural venous plexus is situated inside the epidural space, and during the time of insertion of the needle, that epidural space, the venous plexus, may get injured. At that time there will be bleeding. Okay, so that has to be taken care of when the needle is inserted. Okay. After that, once the epidural space is crossed, then you can see this is the dura mater. Okay, after dura mater you will be getting the arachnoid mater. Okay, once the arachnoid mater is breached, okay, then you are getting into the subarachnoid space. Okay, so once the needle is in the subarachnoid space, at that time what will happen? You can see drops of CSF is coming out through the needle. Once the needle is in the subarachnoid space, okay, few drops of CSF, you can see it is coming out from the needle. That will ensure that the needle is in subarachnoid space. Okay. Now, so what do you think? What will be the length from this particular part? From this particular part, that means from the skin to the subarachnoid space, what will be the distance? You have to measure the distance, right? Unless and until you measure the distance, you can't select the needle. The needle which is used, it is called as LP needle or lumbar puncture needle. If you see the length, it varies from 3.8 to 12.6 centimeter. These are the different length of the needle available. Okay, so for that you have to know this distance in order to select the needle. For each and every individual, the distance is not same. Okay, so the best way is ultrasound guidance. With the help of ultrasound guidance, we can calculate the distance and then we can select the needle accordingly. But it is seen that in case of male, the distance is 4.8 centimeter plus minus 0.68. Okay, and in case of female, it is 4.55 plus minus 0.66. Okay, that is the range, okay, of the distance from the skin to the subarachnoid space in case of male and in case of female. Okay, in various studies it has been found that this is the distance. Okay, so according to that, the needle can be selected. Now, another important point, whenever the needle is piercing the ligamentum flavum. Have you heard about the ligamentum flavum, which is connecting the laminae of the adjacent vertebrae? Lamina. I don't know, you have studied, but still you are confused what is lamina. Okay, please go and study about the vertebrae. So that ligamentum flava, when it is pierced, at that time a pop sound is heard. Okay, that indicates that the needle has pierced the ligamentum flava. Okay, a pop sensation has felt. Okay. Next, there are some indications of the lumbar puncture. Okay, whenever such kind of procedures are done, okay, there are some indications and contraindication. What is the meaning of indication? Why this particular procedure is done? This is the indication. Contraindication means when this particular procedure cannot be done. Okay. So in case of indication, as I said, it is indicated for therapeutic as well as diagnostic purposes. Okay. Now different range of diseases are there in order to find out, for example, if there is any infectious disease present in the central nervous system. Okay, then any inflammatory disease, for example, multiple sclerosis is there, Guillain-Barré syndrome. Okay, then oncologic or metabolic processes. Okay, in order to diagnose all those things, the lumbar puncture is done. Okay, along with that, as I said, it is also done to measure the intracranial pressure. Okay, next, if there is any subarachnoid hemorrhage, If there is any subarachnoid hemorrhage, that can also be diagnosed, because when the hemorrhage will be there, blood will come into the CSF. At that time, once the laboratory investigation is done, blood cells can be found. Blood cell can be found in that particular CSF. Like this, the diagnosis can be done. Okay. Next, with the help of this lumbar puncture only, different medication like analgesic, okay, chemotherapeutics, antibiotics, that can be administered directly into the central nervous system, okay, which will overcome the blood-brain barrier and will go and act on the central nervous system directly. Next, some contraindications are there. That means, contraindication means, suppose a patient came to do the lumbar puncture. At that time, there are certain parameters which you have to check. If those parameters are satisfied, then only it can be done. If it is not satisfied, then this particular procedure cannot be done, and that is called as contraindications. Okay. Now, contraindication includes whenever the lumbar puncture is done, okay, that particular area of the skin, if it is infected, okay, if that particular part of the skin is having certain type of infection, at that time it is contraindicated, okay, it cannot be done. Okay. Next, if there is any lesion in the central nervous system, or if there is any lesion in the spinal cord, okay, or if the intracranial pressure is increased, okay, then if platelet count is less, if patient is suffering from coagulopathies, okay, so these are certain contraindication. That means, in that particular case, the procedure cannot be done. Okay. And mostly nowadays, before doing the lumbar puncture, a CT scan, head of the CT scan is done, okay, to see whether intracranial pressure is normal or not. Next, list of equipment. So, what is the meaning of this list of equipment? So, it is a procedure. Once you do the procedure, equipment are required. Okay, I will give an example. Whenever you are doing dissection, what are the list of equipment required? Whenever you are doing the dissection, what are the equipment required? Scalpel is there, scissors are there, forceps are there, artery forceps, chisel. So many equipment are there. Already you have used few of them, right? Now here, for doing this procedure, a list is there, list of equipment. Okay. Without that, you can't do the procedure. Okay. So a kit is there, that is called lumbar puncture kit. So inside that kit, what is present? As you can see, first of all, spinal needle is there along with a stillet, and you can see the size of the needle, 20 gauge or 22 gauge needle. Okay. Then CSF collection vials are there. That means you have to withdraw the CSF. After withdrawing, where you will keep the CSF? For that, CSF vials are there. Approximately 1 to 4 vials are required. Okay, 1, 2, 3, 4. 4 vials is more than enough. And in one vial, approximately 1 ml is sufficient for do the laboratory investigation. Okay, you can't take more amount of CSF, or you can't aspirate the CSF. Okay, for why? Because there will be reduce in the intracranial pressure. Okay, that is important. Next, sterile drap, then manometer is very important with three-way valve, because with the help of this we can measure the intracranial pressure. Then local anesthetics, syringes, okay. Then disinfecting solution, okay, sterile gloves, face shield, surgical cap, okay. These are the list of equipment which is required. Now, two types of needle are used, okay. I will show you the diagram. Two types of needles are used. Now here you can see the needles and the stillet which are used for the procedure. Okay. Now here you can see two types of needles are used. Okay. So this is called as quincake tip needle, and this is pencil point tip needle. Okay. Now earlier generation, this particular quincake tip needle were used earlier, but nowadays this particular pencil point tip needle is used. This particular needle is more safe as compared to the quincake tip needle. Okay. Why? Because whenever the needle is inserted, if any spinal nerve is coming in between the needle, at that time chances of getting damage to the nerve is very less in this pencil point needle. Okay, which is more in case of quincake needle. The different studies has shown. That's why this particular type of needle is used. Okay, so this is the needle hub where you can connect with the connector, flexible connector to the manometer. Okay, and here you can see this is the stillet. Anyone, have you heard about the needle? I know you have seen the needle. Anyone, have you heard about stillet? क्या होता है stillet? What is the stillet? Actually, it is a rod-like device, okay, made up of stainless steel. Along with that, nitinol is also there. Okay. Now, the needle is used to guide the needle. The stillet is used to guide the needle. That means whenever the needle is inserted, okay, first of all, you can see in the diagram, the needle is inside the stillet, okay, and then it will be inserted. So it can guide the needle once the needle has reached its position, and then after that the stillet can be withdrawn. Now this stillet can also be used along with the cannula. It can be used along with the catheter in various radiological procedures. Okay, so that is the stillet. Next, here you can see the lumbar puncture kit. Okay, so in the lumbar puncture kit you can see the sterile biopsy taping set. Manometer is there. Okay, sterile gloves are there. Then you can see sterile container for CSF, that means the vial. Okay, then you can see the betadine solution, ethanol solution. These are the disinfectant which are used. Okay, then local anesthetics are used, that is the lignocaine local anesthetic, very important. Before pricking it with the needle, the local anesthetic has to be applied in that particular area, okay, or else patient will feel from severe pain. Then you can see the spinal needle. Okay, so this is a entire lumbar puncture kit, okay, where this is under the list of equipment. Okay, next, preparation. Before doing the procedure, some preparation has to be done. Okay, now in case of preparation, first of all, the safety of the patient has to be monitored. That means most of the vital signs are monitored before the procedure. Then you have to explain everything to the patient. You have to fill the consent form. You have to take the signature in that consent form. Okay, I don't know whether you have studied or got in that consent form or not. Before doing such kind of procedure, consent form has to be signed by the patient. Okay, next, what will be the procedure? Okay, so as I said, all the important parameters are checked. Okay, vital signs are checked. Then if patient is suffering from any coagulopathy or thrombocytopenia, that has to be ensured. Okay, and proper steps should be taken. Next, sterile gloves, gown and clean sterile gloves and gown given to the patient. After that, the particular area is disinfected with the help of the betadine solution, okay, in concentric or circular manner. Then that particular area, once it gets dried up, then drapes are used, sterile drape, okay, which will limit the area of the infection. Okay, means sterile drape means before surgery, I hope you have seen a cloth is put over that particular area, okay, and the area which the surgery will be done, that particular area is exposed. That is the sterile drape. Okay, once the sterile drape is put, after that what will happen, the labeling is done. Okay, then the area is clean. Okay, once the sterile drape is done, then disinfection is done. After that, what is applied, that is the local anesthetic. Okay, and then the area is dried. Once the area is dried, then it is ready for the insertion of the needle. Now in the procedure, first of all, you have to identify the landmark. Okay, now how we will identify the landmark? Already I told you, we have to take the highest point of the iliac crest. To iliac crest, highest point has to be taken. Okay, and we have to draw a line. So the midpoint will be the line through which the needle has to be inserted. Okay, now once we are selecting that particular area in which we will insert the needle, okay, a marker is there. Okay, that marker is used to mark the area. Okay, so that the needle can be inserted from that particular part. And before insertion of the needle, okay, we have to take ultrasound guidance. Before insertion of the needle, ultrasound guidance is taken. Okay, so here you can see the spinal needle should be inserted with stillet in the place okay, of sagittal plane. So with the help of the stellate only we will be inserting the needle. Okay, now the bevel of the needle should face towards the ceiling, okay, in the left lateral decupitous position. Next, this will spread the fibers of the cauda equina instead of cutting them during the insertion. Okay, so left lateral decupitous position will help to spread the fibers so that when the needle is inserted, it will not cause much damage, or it will not cause any damage to the fibers. Okay. Now, when the needle is inserted through L4 or L5 interspace, it should be inserted along the superior aspect of the L5 spinous process. Okay, superior part of the L5 spinous process, that area is selected, and approximately 15-degree angulation, that also cranially, must be given to the needle. Now, palpation of the landmark, as I said, that is also important. So, in this diagram, you can see how the landmark is palpated. Okay, with the help of the thumb, and then you can see with the help of the marker, the marking is done. Okay, through this marking only the needle has to be inserted. But once the marking is done, okay, it is not that you will be inserting the needle directly. Nowadays blind techniques are not used because different types of guidance are available. Okay, so in that case what is done, ultrasound guidance is used. So with the help of the ultrasound guidance, the needle is introduced. Okay, because see, whenever the needle is introduced, as I said, so many layers are there which you have to encounter. Okay, now what happens, sometime instead of going through the intervertebral disc, okay, the needle can go and hit the body of the lumbar vertebra. Okay, so you will feel a hard substance and the needle is not going further, CSF is not draining. In that case, what you have to do, you have to take out the needle and again you have to insert. Okay, and that is not comfortable for the patient, it is painful for the patient. Okay, so that's why nowadays what happens, ultrasound guidance is taken. So with the help of the ultrasound guidance, the subarachnoid space can be diagnosed very easily, because CSF is present, so the texture of that particular area is different as compared to the bony areas. Okay, and the direction of the needle, that means when the needle is inserted, continuous monitoring of the ultrasound guidance is required. Okay, that will guide the needle, because once it is going inside, you can't see through which layer or through which structure it is going. So for that, ultrasound guidance is taken, so that will guide the needle unless and until it reaches the subarachnoid space. Okay. Next, if any blood vessel comes in between, that can also be seen with the help of the ultrasound. Okay. So the chances of getting injury with the help of ultrasound guidance is very less. That's why blind techniques are not used. Okay. Now, so the line which is intersecting the spine at the L4 spinous process, it should only serve as general reference. Okay, because there may be some anatomical variation. Okay, for example, in case of obese people, okay, in case of obese people, or suppose person suffering from scoliosis, okay, which is a pathology related to the vertebral column, in that case it is very difficult. That's why it is suggested to use ultrasound guidance. Now, once the interspinous space is palpated, the skin marking pen, as I said, it is used, okay, through which the needle has to be inserted. Okay, so as you can see, the hollow needle which is inserted, it should be go in cranial direction, cranially, 15-degree angulation is given. Okay, now ultrasound guidance is taken. Along with that, you can see no bony structure is coming in between. First, you have to ask the patient to do flexion of the trunk. As you can see here, the patient is lying down in left lateral decupitous position. Okay, and then the flexion is done. Once the flexion is done, the interspinous space increased. Okay. Next, as I said, once we take the ultrasound guidance, that will help us so that the needle will not prick or will not puncture any bony structure. Now, please see the diagram. Here you can see all the soft tissues are being punctured, and then the needle is reaching the subarachnoid space. Okay, no bone is coming in between. Okay, so that that is the most important point, okay, because if any bony structure is coming, the needle won't go. Then again you have to take out, okay, and then again you have to insert it properly. Okay. Now, as I said, when the ligamentum flavum is pierced, a pooping sensation can be felt. Okay. Now, after that, advancing the needle in 2 millimeter increment each time, removing the stilet to see whether CSF is draining or not. Once the ligamentum flavum is crossed, after that 2 millimeter needle increment, then you have to stop and you have to see whether CSF is coming or not. Okay. Now the needle which we have selected approximately 2/3 depth has to be inserted so that it can cross the ligamentum flavum. Okay. Next, if bone is encountered, okay, then CSF fluid will not be obtained. In that, the needle is withdrawn to the subcutaneous tissue without exiting the skin, and then again the needle is redirected. Okay, that means any bony structure is encountered, then what you have to do, you have to take out the needle, not entirely, up to the subcutaneous tissue, and then again it is redirected towards the subarachnoid space. Okay. Next, what else can happen, that is the traumatic lumbar puncture. Now what is this traumatic lumbar puncture? In that case, the bleeding may take place, and it typically occurs when the epidural venous plexus are pierced by the spinal needle. So already I mentioned, in the epidural venous space what is present? Venous plexus is present. Okay. So blindly if the needle is inserted without taking any help of the ultrasound guidance, then there are chances of causing damage to the epidural venous plexus. As a result, profuse bleeding will be there and blood may clot in that particular area. Okay. Now if this occurs, then new spinal needle at a different site is advised. At that case, you have to take out the needle entirely and a different site is used in order to insert the needle. Okay. So ultrasound guidance has shown proper improved success rate. That means once the ultrasound guidance is used, the success rate is higher without getting any injury. Now you can see in this particular diagram, so this is the drape which is used, this is the area. Okay. Now here you can see the ultrasound probe is used. Okay. And along with the ultrasound probe, you can see the needle which is inserted. So throughout the needle insertion, the ultrasound probe will be there because it is the guidance. It is showing the guidance, means it is showing the pathway through which the needle has to be inserted. Now if you see this particular part, you can see the ligamentum flavum. Okay. Now in this particular part, you can see the needle and you can see the tip of the needle in intrathecal space. Okay, where the CSF is present. Okay. So with the help of the ultrasound guidance, which particular part is bone, which particular part is ligament, whether any blood vessels are there or not, that can be seen easily. Okay. After that, the needle can be redirected so that it will not cause any damage to the structures. Okay. Next, here you can see this is the vial. Can you see the drops of the CSF which is coming out? Okay. Like this, 3 to 4 vials are used, in which drops of the CSF which will come out, it will be stored. Okay. And then further it will be sent into the laboratory investigation. It will be sent for laboratory investigation. Okay. Now, so this is the USG guided, ultrasound guided lumbar puncture. So with the help of the ultrasound guidance, first we can measure the distance. Okay. We can see the tip of the needle, and then if there is any structure which is coming in between, okay, which can get injured, that can be prevented with the help of ultrasound guidance. That's why these days blind technique is not used, ultrasound guidance are used. Okay. Okay. Next, I have mentioned that once the CSF is obtained, okay, we have taken out few ml of CSF. Then what we have to do? We have to measure the intracranial pressure. So for that, what is required? In order to measure the intracranial pressure, manometer is required. Okay, I will show you the diagram of manometer. Okay, so once the CSF flow is reached in the needle, okay, now we have to measure the intracranial pressure. Okay, now for that, what we have to do? We have to attach the manometer to the spinal needle by using a flexible connector. So flexible connector is there, one end is attached to the needle, another end is attached to the manometer. Once it is attached to the manometer, at that time what will happen, will allow the CSF fluid level to rise in the manometer. Okay, it will go inside the manometer. At that time the fluid, the CSF which is going into the manometer, it will rise depending on the pressure. After that we have to document, we have to measure what is the pressure and it has to be noted. Now nowadays digital is available, but in some cases it is not digital. So if it is not digital, what you have to do, you have to document, or you have to write it down what is that pressure exactly in that particular point. Okay, so normal range is 6 centimeter to 25 centimeter of water. Up to that range it is normal. If it is beyond that, then the intracranial pressure is higher. Now after obtaining and documenting, okay, the pressure, the tube is removed. Now let me show you the, so this is the spinal manometer. Okay, so this is the spinal manometer. Now just see how it is connected. Okay, so see, this is the spinal needle with three-way stopcock. Okay, and this is the flexible connector. So this flexible connector, one end is attached to the spinal needle three-way stopcock, and another end is attached to the manometer. Okay, once it will start flow inside the manometer, okay, the CSF column, by looking at the CSF column, the intracranial pressure can be measured. This I am talking about the manual one, not the digital one. Okay, so from here we have to see what is the pressure, and then it has to be documented. Means it has to be written at that particular point. Okay, so like this, the pressure, intracranial pressure, can also be measured. Okay. Okay, next there are some complications. Okay, because see, whenever the procedure is done, you are inserting the needle. Okay, so there must be some complication. I am not telling in each and every case complications are there, but complication can occur. So what are the different types of complication which can occur? So first of all, you have to understand the risks which are associated with the lumbar puncture. Okay, so that the proper precaution can be taken. Now it include post-lumbar puncture headache, very common. Okay, post-lumbar puncture headache, that means you have to inform the patient that headache will be there after completion of the procedure. Okay, bleeding will be there, infection, spinal hematoma. Okay, bleeding will be there, infection may be there, spinal hematoma, that means the collection of the blood epidural in the epidural space. Okay, so these are the most common types of complication. Now in order to reduce the complications, especially the bleeding, okay, as I said, a special type of needle is used. Okay, a traumatic spinal needle, or also called as pencil point spinal needle, which already I have shown you earlier. Okay, so that can be used. So with the help of that particular needle, the injury can be minimized. Now so here I have shown you how the pressure is measured. Once the pressure is measured, after that what has to be done? This particular connector has to be detached. Okay, then gradually the needle has to be taken out. Once the needle is taken out, then sterile dressing is applied with the help of a bandage. Okay, and then you have to keep the patient under observation, whether hematoma is taking place or not, whether pain is there or not, whether any inflammation is taking place or not. For that you have to keep the patient under observation for few hours. Okay, and then the patient can leave the department. Okay, so those are the points which must be known for the complication. Okay, so that is all about the lumbar puncture. Okay, so today in lumbar puncture we have seen first of all few important points related to the vertebral column and spinal cord. Okay, then what is the lumbar puncture, how it is done. In your syllabus, CBME based syllabus, there is a topic which is special radiographic procedure for abdominopelvic region. Okay, where you have to study about the barium series. Okay, barium studies, barium meal, barium swallow, barium follow through, barium enema. Okay, like this you have to study. It is there in your syllabus, and before this second internal exam you have to study, and those from those chapters question may be asked in the second internal. Okay, so whatever points I have shown you today, okay, you will see that similar type of points are mentioned about there. For example, if suppose any procedure is there, barium meal, barium swallow, at that time you have to write about those introduction, then indication, contraindication, list of equipment, patient preparation, then complications, okay, procedure, and then complication. So all those points are similar. So today it was a introduction to those particular points. As we will go further, okay, into those procedure, at that time again those points will be repeated. Okay, so why I am mentioning this point, because in the exam you have to write exactly, instead of writing 2-3 pages in paragraph. Okay, it's better to write those points, write those heading and explain in brief. Okay, that makes sense. Okay, so that's why I have added this point. Okay, so that's all about the lumbar puncture. Thank you everyone.